Alport syndrome, defined as an inherited kidney disease, also referred to as hereditary nephritis, caused by genetic mutations affecting the structure of type 4 collagen, a key protein in basement membranes, considered the most common form of hereditary glomerulonephritis, inflammation of the kidney's filters. Most frequently inherited as an X-linked trait, affecting 70 to 85% of families due to mutations in the COL4A5 gene, can be inherited in an autosomal recessive pattern, about 5 to 15% of cases, caused by mutations in both copies of the COL4A3 or COL4A4 genes. Rarely follows an autosomal dominant inheritance pattern, about 19 to 31% of cases, linked to mutations in the COL4A3 or COL4A4 gene locus. The COL4A5 gene mutation in the X-linked form affects the alpha-5 chain of type 4 collagen. The COL4A3 and COL4A4 gene mutations in autosomal forms affect the alpha-3 and alpha-4 chains of type 4 collagen, respectively. Around 10 to 15% of X-linked cases arise from new mutations, meaning there is no prior family history. Primarily affects the kidneys, ears, and eyes because type 4 collagen is crucial for the basement membranes in these organs. Kidney involvement manifests as progressive glomerulonephritis, leading to declining kidney function over time. All patients experience microscopic hematuria, although it can be intermittent, especially in females or young males. Persistent microscopic hematuria often appears very early, sometimes during infancy or toddler years, particularly in affected males. Approximately 50–70% of patients have episodes of gross hematuria, often coinciding with respiratory infections. Proteinuria usually develops after hematuria and tends to worsen over time, particularly in males. In about 30% of males with the X-linked form, proteinuria becomes severe enough to cause nephrotic syndrome. Can be classified as a cause of secondary nephrotic syndrome. Kidney disease progression is typically severe in males with the X-linked form. Roughly 90% of males affected by X-linked Alport syndrome will progress to end-stage kidney disease, ESKD, by age 40. Females with the X-linked form usually experience a slower progression of kidney disease. About 12% reach ESKD by age 40, increasing to 30% by age 60. The severity of kidney disease in females with X-linked Alport syndrome varies widely. In the autosomal recessive forms, both males and females experience severe kidney disease progression. End-stage kidney disease typically develops between the second and third decades of life in males with X-linked disease and in individuals with autosomal recessive disease. Associated with characteristic bilateral sensorineural hearing loss. Hearing loss is not congenital, but develops gradually over time, often after kidney disease becomes apparent. The hearing loss is progressive, typically affecting high-frequency sounds first. Hearing loss eventually affects about 90% of males with X-linked disease, 20% of females with X-linked disease, and around 67% of those with autosomal recessive disease. The severity and progression of hearing loss often correlate with the rate of kidney function decline. Eye abnormalities are found in approximately 30 to 50% of patients. Characteristic eye findings include anterior lenticonus, flecks in the macula, and recurrent corneal erosions. The presence of anterior lenticonus is considered a highly specific sign for Alport syndrome. Other potential eye problems include cataracts and retinitis. A rare association exists between Alport syndrome and diffuse leiomyomatosis. Epstein syndrome is a related condition combining Alport syndrome features with macrothrombocytopenia. Fechner syndrome involves macrothrombocytopenia and Alport-like features due to MYH9 gene mutations. Kidney biopsy under electron microscope reveals distinctive glomerular basement membrane, GBM changes. Typical GBM findings include thickening, thinning, splitting, and lamellation, basket weave pattern. In early stages, electron microscopy may only show diffuse thinning of the GBM. Light microscopy may show minimal changes initially, later revealing glomerulosclerosis, tubular atrophy, and interstitial inflammation. Diagnosis is aided by a detailed family history. Urinalysis on first-degree relatives can help identify a familial pattern of hematuria. Audiometry and eye exams are essential parts of the diagnostic workup. Skin biopsy can assess alpha-5/4 collagen staining to confirm X-linked Alport syndrome. Genetic testing identifies COL4A3, COL4A4, or COL4A5 mutations to confirm diagnosis and inheritance. Treatment strategies are supportive, focusing on managing symptoms and slowing kidney disease progression. ACE inhibitors or ARBs reduce proteinuria and slow kidney failure progression. End-stage kidney disease requires dialysis or transplantation. Transplanted kidneys have normal collagen, so the genetic defect does not recur in the graft. A rare post-transplant complication is anti-GBM disease, affecting 3 to 4% of patients. Regular hearing screenings help detect early hearing loss and support intervention. Sources: American Academy of Pediatrics Textbook of Pediatric Care, 2017, pp. 2412-2417, 14.67. Nelson Textbook of Pediatrics, 22nd ed., 3223, 3259, 3290, 4027. Current Diagnosis and Treatment, Pediatrics, 25th ed., pp. 1304-1305, Guy Essential Pediatrics, 10th ed., CBS, p. 5 and 22. Swayman's Pediatric Neurology, Principles and Practice, 6th ed., p. 69. Illustrated Textbook of Pediatrics, Elsevier, 2021, p. 373.